So welcome to the third part of week 7, and in this third part we're going to give an example of a model-based cost of illness study. My colleagues and I conducted this study some years back, and it was on the cost of induced abortion in Uganda. And this is a problem in many poor countries because abortion is illegal. And because it's illegal, it goes underground. So it's performed in clandestine areas, in clandestine clinics. And given that, they are usually unhygienic and they use all kinds of methods. And this results in a high number of complications, and the complications have a high cost burden, so they can affect costs substantially. So this paper was published in BMC Public Health, and I added it to your reading list. If you're so inclined, you might consider reading it. And since I was one of the co-authors, I hope that it's not too difficult of a read. So as an introduction, abortion is not just illegal in Uganda, it's also the subject of substantial social and religious stigma. But the problem is that the demand for induced abortions is high. You have some 700,000 induced abortions carried out on an annual basis, and the main cause of this is unintended pregnancies are high, and the downstream reason for that is that there's low access to modern contraceptives, just 31%. So illegal abortions are usually unsafe, like I said in the previous slides, and they are performed underground in clandestine locations. And the practitioners, the people who perform these abortions, are poorly trained. So there's a high rate of severe complications, especially injuries to the uterus and the cervix and the vagina, and then you have another problem of infection, and these complications consume a large amount of healthcare resources. So the idea was to try and quantify this resource burden of these unsafe abortions. The reason we did this study was we wanted a more comprehensive estimate of the societal costs associated with induced abortion in Uganda. We wanted a Uganda-specific estimate, and we thought that highlighting the problem would contribute to the policy discussions towards providing safe abortions to reduce not just the outcomes burden, the morbidity and mortality, but also the cost burden. And the reason we did the study is that other studies had not included things like the costs of failed abortions, failed inductions, and some procedures, and they hadn't included some direct non-medical costs like transportation of patients. So we wanted to get a better picture of the illegal abortion situation in terms of costs in Uganda. So looking at the methods, we used a decision tree, and we're going to look at the tree. And we used it to organize the consequences and complications of induced abortion. And then we obtained data for the probabilities of clinical events and complications from the published literature. We also did a primary chart abstraction to get the costs of abortion complications. And we got data from the literature for other costs. So we needed to include other costs. And we estimated direct medical costs, direct non-medical costs, and productivity losses. And we also did it from the perspective both of the government and of the society. So we wanted to estimate uncertainty. We wanted to see what the uncertainty around the different estimates would be. And we decided to do a Monte Carlo simulation and estimate 95% credibility ranges using this method. And as we saw in week 3, you need to report costs in a standard year, and our year of reference for this study was in 2010 US dollars. So here is the decision tree, and I'm saying decision tree, but it's really a health outcomes tree. It's a health outcomes tree, and the reason it's a health outcomes tree, is that we don't have a decision. This was not a decision analysis. It was using the method of decision analysis to organize the analysis and the data and be able to come up with an estimate of induced abortion. So there's no decision node in this tree. You aren't going to see a decision node, which is usually a square. So a woman who induces an abortion might do it with a trained provider or with an untrained provider. So the first node is actually a chance node. This is a chance node. The index node in the model is a chance node. So we're saying decision tree, but we're using the word decision tree as a reflection of the method, but not a reflection of the decision. So because we don't have a decision, it's not like a cost effectiveness analysis. And this points to the difference between cost of illness and the other economic evaluation methods. Is in other economic evaluation methods, you're trying to compare two or more interventions with regard to their costs and consequences, but here you're trying to describe the burden of a disease. So once it was a trained provider, maybe it would be a doctor, a clinical officer, or a nurse, or a dispenser, a lay practitioner, or it would be self-induction. If induction was successful, there could be a complication or no complication. If it failed, you could get pregnant and maybe miscarry or have a live birth, a hospital birth, a home birth, and then you have live and die. And you could have a complication and need hospital care or outpatient care. You get access to care, and depending on access, then you get a delayed hospital visits, and then you have survival and mortality. So this was the tree we used to organize the data. And everything for clinical officer, nurse or midwife, dispenser, lay practitioner, and even self-induction. These are the methods of abortion by a doctor, by a clinical officer, a nurse, a dispenser. All these have the same exact tree. So this is what is called a clone. So the clone means that you go to here, you go to a similar branch. The only thing that's different is the different probabilities. So for a medical doctor, you would have a smaller complication rate, for example. So this is what we call cloning. So everything for the other practitioner is a clone of this branch. These branches all apply for here. So it's called a clone. So here are the data that went into the model. You have providers. The probability that you get an abortion by a trained provider is 56%, untrained 44%, whether it's a doctor, a clinical officer, whether it's an untrained provider, whether you induce yourself, 34% of those who go to untrained providers do self-induction. Then you have a probability for induction failure. Then you have complications, and like you can see, like we said in the previous, when we're giving the example in the previous slide, doctors have a smaller probability of complications than clinical officers and even nurses, and dispensers and lay practitioners and self-induction have higher probabilities of abortion complications. So that's the disadvantage of not having a doctor do the abortion procedure. So as you go down, you'll see a higher probability of abortion complications as the level of sophistication of training reduces. And for complications, you have in the hospital, you have treatment complications that happen in the hospital is 44%, outpatient treatment 56%, and access to care is about 70%. And then mortality is 2% in the hospital and 5% in the community. And you'll notice that the 5% was an assumption. We didn't have an empiric estimate for that. And then we had pregnancy outcomes here. So if you get pregnant, 87% have a birth, 3% miscarry, 10% miscarry greater than 13 weeks. You have a hospital delivery 40% of the time, and then you have perinatal mortality in hospital and in the community. So these were the data that informed the different branches, the different branch probabilities, as we saw in the picture in the previous slide. And then switching to costs. So we had the costs of the abortion procedures in 2010 dollars. Of course, the doctors are more expensive, so the costs go down as the sophistication of the provider goes down. So you can see that doctors, it's nearly $100, clinical officers nearly 60, nurses 40, dispensers 17, lay practitioners a bit higher, 37. Self-induction is cheap, and you have productivity losses. Productivity losses were estimated based on the amount of time people lose, when they are seeking abortion care. And we had the cost of complications here in the hospital. We had personnel, supplies and drugs, and overhead and capital and productivity losses. So we estimated all the different kinds of costs. And then for outpatient complications, we had the same thing here for personnel, drugs, supplies, overhead and capital. And then we had other costs: antenatal care, if you get pregnant, hospital delivery, transportation and upkeep, which are direct non-medical costs, and out-of-pocket payments, which are also direct non-medical costs. And to adjust for productivity losses due to premature mortality, we had an annual productivity loss of $474, which is essentially the GDP per capita at the real exchange rate for the country of Uganda. So these are the data we used. So here are the results. This was the average costs in 2010 dollars of induced abortion by different cost categories. So for direct medical, you had 65, direct non-medical 19, productivity losses 92, government 14, patient 61, and the societal cost was $177. So this was the estimate of the cost of abortion, of a single abortion, the mean cost of an abortion in Uganda. And the scenario analysis, the minimum cost is about $115 and the maximum would be about $275. And we had this Monte Carlo simulation generated 95% credibility range, which we presented as the estimate of uncertainty. And it's not a confidence interval, it's called a credibility range because it's generated from a simulation exercise. And we used Monte Carlo, but you could also use a bootstrapping exercise. So that's why it's called a credibility range and not a confidence interval. So we try to estimate the potential national cost impact, and we had an estimate of 362,000 abortions on an annual basis, and we multiplied that by the mean cost, and we estimated that we would project some nearly $24 million in direct medical costs, $7 million in direct non-medical costs, $36 million in productivity losses, $6 million in costs to government, $22 million in costs to patients, and $64 million in societal costs. And for a country that has a GDP of $18 billion per year, this $64 million is not trivial for a single disease area, for a single adverse event, like the complications of unsafe abortion. So in my view, and you can disagree with me, $64 million in societal costs for induced abortion is a high burden of disease. So the conclusion of our study was that abortion leads to a substantial cost, and it reinforced the case made by other researchers that efforts to reduce induced abortions by increasing coverage of contraceptives and providing safe legal abortions are critical to reducing this burden. The legal question is a very tricky question, and this area is actually quite controversial, and working in this area can lead to people assigning you names essentially and saying you're pro or against abortion. But I like to think of we health economists as not putting our personal beliefs into the analysis, and this is just what the data say. Given this burden, the country should consider, at least providing increased contraceptive coverage. and that the costs associated with induced abortion in Uganda represented a substantial burden to the healthcare system. And we could also use these estimates as inputs into economic evaluations that assess policies for increasing contraceptive coverage. And actually, we used this estimate in a study that I might have shown you, which was the cost effectiveness of increasing contraceptive coverage in Uganda. And I must have showed it to you in the Markov modeling lecture. So we used estimates from this study to inform the parameters for that study. Before I finish, I wanted to reinforce sensitivity analysis with this figure which came from this particular study. It's called a tornado diagram. A tornado diagram. And a tornado diagram shows the impact on an estimate, a model-based estimate of changing different parameters. So the most significant parameter, the parameter that leads to a change in the outcome, the biggest change in the outcome is put at the top right here. And that's why it's called a tornado diagram, because it's shaped like a tornado, like that. So you start with the one that has the biggest impact on the outcome. So here is the societal cost. This is the base case societal cost of induced abortion, around $177. So it means that changing the probability of in-hospital abortion-related mortality was the most sensitive parameter, because changing it could change the answer between $200 and $156. So if you had the probability of in-hospital mortality at 0.01, then it means that the societal cost of induced abortion would go down to $156. And if you increased the mortality to 3%, then the cost would go up to $200. So this is how you present a sensitivity analysis. And in the literature, you'll find many one-way sensitivity analysis presented as tornado diagrams. So if you find a tornado diagram, this is how to interpret it. And each bar represents a single parameter. So for example, the third one here, the third bar here is access to health services for abortion complications. And at 50% access, the costs would be about $163. And if you increased access to 83%, which was the plausible range, the cost of abortion would be about $190. So it would be there. So that's how you interpret a tornado diagram. If you see it in the literature, in papers, it's a representation of one-way sensitivity analysis with the parameter that has the highest impact on results. We also call that the most sensitive parameter at the top, and it's shaped like a tornado. So these parameters down here are very robust, because changing them through their plausible ranges, these ranges in brackets here, changes the results very little. So we say that the model is robust to these ones and sensitive, robust to the ones down here and sensitive to the ones that are up here. But for this analysis, for this particular analysis, this wasn't too sensitive anyway. The most sensitive parameter wasn't too sensitive because it only changed the base case estimate from 177 to 200, and from 177 to maybe 160. So it was a relatively robust result for this particular modeling exercise. So that's the end of part 3 of week 7, and it marks the end of week 7, in which we have talked about cost of illness or burden of disease. And I hope that you will at least be able to recognize papers that report on cost of illness and know the methods that they used, and that at least some of you will be inspired to perform your own burden of disease studies or cost of illness studies if you are so inspired and you have a disease area in which you're interested. Thank you very much, and I'll see you in week 8.